I'm Rich Besser. I'm the Chief Health and Medical Editor at ABC News, and it's a real pleasure to be here today to moderate this panel, or these panels. Over the past year, ABC News has had a collaboration with the Duke Global Health Institute around our work and our coverage of global health stories. We received some support from the Bill and Melinda Gates Foundation to try and shine our cameras on global health stories. But in order to do that in a way that was true, we needed research support. And we turned to Duke, and I want to thank Mike for supporting these efforts with staff, with research time, so that our stories could be as true as we could make them. I think you're in for a real treat this afternoon. 3 panels of experts covering a wide range of global health issues. The goal is to try and get a conversation going between them and with you in the audience. And to accomplish that, I'm going to be a real tyrant up here. Each person has 5 minutes, and I've got to watch with the sweep second. And I'm going to hold them to 5 minutes. And so if they're not able to get in all of their comments during the discussion, they may be able to make some of their points. But I do want to turn this into a conversation rather than a day of lectures. So the first panel is on chronic disease. And as Mike was mentioning, the UN took up this issue just a week ago. The idea of non-communicable diseases as a global priority is one that many are coming to. The idea that once you've vaccinated the world's population, you've done with global health or addressed malaria and HIV is now changing. By 2030, it's estimated that non-communicable diseases will account for 70% of global deaths, and 80% of those deaths will take place in low and middle income countries. And so the question comes, do the systems we have in place, are they able to address non-communicable diseases? Will there need to be a shift in how we do this? Will there be resources to address these problems, especially in a global climate the way it currently is? So I'm going to do a very brief introduction of today's panelists, and then we're going to get into it so that you're able to hear them and not me. And I ask you to look at your programs for more detail on our speakers' backgrounds. We have 4 panelists. Gary Bennett is the associate professor. He's an associate professor in psychology and neuroscience and global health. Jerry Bloomfield is assistant professor in medicine and global health. David Walmer is associate professor of obstetrics and gynecology and global health. And Lijing is head of research and development and director of China International Center for Chronic Disease Prevention, the George Institute for Global Health in China. And our first speaker will be Gary Bennett.
Thank you.
Do you need a...
Yes, thank you. Well, good afternoon. It's a pleasure for me to be here today to talk about our work and to represent some of my colleagues. So I think, as Richard just mentioned, there's been quite a lot of excitement in the last couple of weeks in the global health community, particularly for those of us who study chronic disease as a function of the UN's coverage of chronic disease in its recent meeting. And you know, that work and that focus tends to come out of work like this, which suggests that 14 million deaths in the developing world could be prevented by focusing on well-known chronic disease prevention strategies. If we look out 20 years and we project the, if we look out 20 years and by 2030, if we look at the projected causes of disease burden, you'll notice a couple of things. One is they look very different than what they look like now, and we'll see a shift towards a greater emphasis on chronic disease, including mental health. The second thing is that many of these leading conditions can be either prevented or their risk can be dramatically reduced using behavioral interventions and other types of evidence-based preventive strategies. The third thing is that many of those whose risk can be reduced can be addressed by focusing on diet, physical activity, and obesity. This has become a major concern of ours, the 1.5 billion people worldwide who are overweight. That makes it in absolute terms a bigger problem than is famine or chronic hunger, conditions that we tend to think of as being more associated with kind of classic global health crises. And of course, in Western countries still are those that are most affected by overweight and obesity, but we're seeing rapid increases in places like China where we've been doing some work. The reasons for that aren't really elusive. I hope some of you can see that at the bottom, but if you can't, what you'll see is a Coca-Cola sign, which if you've been to a developing nation, you'll see just about everywhere. KFC, which if you've gone to Beijing, you'll see just about everywhere. And massive amounts of traffic. And that is, as we start to see greater shifts towards Western norms and urbanization, you tend to see the food industry move in, and norms change, food changes, and dietary and physical activity patterns change, hence bringing on an obesity epidemic. The problem, I tend to agree with most of my colleagues and many of you in the room, I think, who would say that we can best address problems like obesity at the policy level. I would agree with that. We're still left with 1.5 billion people who are overweight or obese right now. And so our work is designed to try to identify effective, evidence-based obesity treatment strategies that can be widely disseminated at very low cost. We've started here in the US, and now we're starting to move globally. In all populations, treating obesity is about shifting the energy balance away from what you see here towards something that looks closer to what you see here, where we see energy expenditure essentially more than energy intake. You can get there in a lot of ways, and one of the easiest ways is counting calories. But if you live in a developing country or most of the world where calorie information isn't presented on food products, or if you've just tried to count calories for more than about 2 days, you'll realize the challenge associated with that. So we've developed an approach about 5 years ago that we call the interactive obesity treatment approach, which basically says you can create an energy deficit that's sufficient to produce weight loss by having folks focus on several very, very simple, commonly understood behaviors, things like making a specific recommendation about fruit and vegetables, a specific steps recommendation. And we've created computer algorithms that prescribe effectively very simple behavior changes that people can do. Again, these are sufficient to promote an energy deficit. People do these behavior changes and they lose weight. Now, I think we may have hit 2 or 3 of those game changers that were mentioned earlier, because in our work in the interactive obesity treatment approach, we make copious use of mobile health technologies. And when we started this work 4 or 5 years ago, people looked at us askew whenever we talked about using cell phones or websites and things in disenfranchised communities in the US. But what we find is that abroad, the penetration of mobile technologies is very, very large. And so we're able to reach people in ways that we were never able to do before. So we've invested heavily in this space. This also helps us to provide evidence-based treatment strategies to providers. So this works both in putting information in front of patients, but also in front of providers as well. And to date, we've done 4 randomized controlled trials here in the US that demonstrate the efficacy of this approach. And we've started to move it abroad, and we're starting with China. And that's because even though in absolute terms, the level of overweight is nowhere near what it is in the US, the epidemic there is increasing at a faster pace than it did in the US. And as a population, Asians have a lower obesity tolerance, meaning that they experience health consequences, type 2 diabetes, cardiovascular disease, at lower levels of obesity than we do here in the West. And so it makes the even very low levels of weight gain very concerning from a public health perspective. So our approach and what we've been doing works very well. It does a variety of things that seem to be associated with cardiovascular disease prevention, type 2 diabetes prevention, and I'm hoping that we can come back at the 10th year anniversary of the DGHI and talk about all the success that we've had in curbing some of the obesity in China. Thank you.
Thanks very much, Gary. Again, be thinking of questions that you want to ask. We're gonna get to those soon after the talks. Our next speaker, Jerry Bloomfield.
Thank you very much. Is this on? Yeah. Thank you very much, and thank you to the organizers of the symposium for the opportunity to be part of this very distinguished panel. What I'll speak about here in the next few minutes are non-communicable cardiovascular diseases in Kenya, focusing on Kenya because that's where a group of us from Duke have been doing a lot of interesting and exciting work for the last few years. I have no disclosures. Cardiovascular disease in Sub-Saharan Africa is interesting from a historical perspective. For the majority of the last century, it was felt that non-communicable diseases were exceedingly rare in this region of the world. The common cardiovascular diseases, rheumatic heart disease, heart failure, were largely due to infectious or inflammatory issues. Coronary heart disease, which is very common in the US and in many other developed nations, was felt to be exceedingly rare. So rare that prior to the 1980s, I don't know if you can all see this line here, but there was actually suggestions in the published literature that Africans might be biologically immune to coronary heart disease. And it wasn't until the late 1990s that the link between development and non-communicable diseases were made. As this quote says, as long, I apologize, you might not be able to see it, as long as Africa remains impoverished, a major rise in coronary heart disease is unlikely. Unfortunately, there has been a major rise in cardiovascular disease in sub-Saharan Africa. These data would suggest that these rises are present in both urban and rural settings amongst men and women, although there are some sex-based differences, and especially amongst people who are in the prime of their lives and working years. This graph illustrates that last point. This shows the mortality due to cardiovascular disease, the cumulative mortality from the year 2000 to the year 2030 by age group. And what I'm showing here is that for South Africa, which is representing sub-Saharan Africa, 41% of the deaths due to cardiovascular disease will happen in people who are of working age. The corresponding figure for the US, representing a lot of the developed nations, is about 12%. So 41% of people who are dying of cardiovascular disease will leave families behind, will often be the only wage earner, will be key people in their community, and often will be healthcare workers as well. So one thing we've done here at Duke is to create a cardiovascular and pulmonary disease center of excellence in Western Kenya, illustrated here on this graph, based on the AMPATH program, which is an access to healthcare program in Western Kenya. Our center of excellence does many things, and what I'll spend the next minute or so talking about is one demonstration project that we have going on looking at the link between HIV and non-communicable cardiovascular disease. The backdrop for this, as we heard and we know, HIV and its treatment is pervasive in sub-Saharan Africa. And we know from studies in the West that there's a link between HIV disease, HIV treatment, and cardiovascular disease. So we set out to look at a large number of patients, about 12,000 HIV-positive patients from Kenya, and found that there was an 11% prevalence of hypertension among HIV-positive men. About 40 or 50 years ago, this number was estimated to be around 1 or 2%. And amongst women, there was a 24% prevalence of overweight or obesity. So what we've done in response to this is actually start some early detection and treatment programs. What I'll end here in the limited time we've been given is a quote here that there's a rare opportunity for primary prevention in sub-Saharan Africa, I believe. So this graph on the x-axis demonstrates all low and middle income country regions. High income countries have been excluded. And on the y-axis is the share of deaths due to communicable diseases in the dark color and chronic and non-communicable diseases in the orange color. And for every other low and middle income region in the world, there's already been the shift in the highest mortality happening due to non-communicable diseases, except in sub-Saharan Africa. And I think there are 2 points that I'd just like to highlight here. Number one, the communicable disease agenda is unfinished, and there definitely needs to be attention paid there. But we do have a rare opportunity to institute some true primary prevention for non-communicable cardiovascular disease in an area of the world where we have not yet made the shift in this change in mortality. And I think we can do that with good prevention programs, diagnostics, and cost-effective treatment. Thank you.
Thanks, Jerry. Lijing, are you up next, or is David?
I think I'm up next.
You're up next. Okay. Take it away.
Thank you, Richard. I'd like to thank Mike and John for inviting me to be here. I've traveled across about half a globe and have a complete switch of night and day to be here. So if I can't find the right word, I'll blame it on the jet lag. Well, it's truly a delight and an honor to be here and to share with you some of the things we've been working on with the DGHI and the wider Duke community, which is a small piece of evidence of the tremendous achievements the DGHI has had over the past 5 years. Given the interest of time, I will focus on a large-scale study called China Rural Health Initiative for today. Here, this graph gives you some background of the study. We show here the death distribution by causes of death for China according to the most recent estimate in 2008. You can't really see the label below, but the left panel is urban, the right panel is rural. The point of this graph is that non-communicable diseases represented by red, pink, purple, and yellow they represent over 80% of all deaths. This is true for both urban and rural China. And you know that our rural China has the largest number of disadvantaged population in China. So in rural China, there is an enormous burden of premature cardiovascular disease in comparison to Sub-Saharan Africa. The burden is really about as high as the urban areas. But awareness and control are low and resources are limited. We also know that there are a lot of evidence-based guidelines, but they're not well implemented in rural areas. Therefore, our study is aimed to address these kind of issues. The full title of the study is called High Cardiovascular Risk Management and Sodium Reduction in Rural Villages, a cluster randomized controlled pragmatic trial. So you can see from the title that there are two interventions. One is a high-risk based approach geared toward high-risk individuals for cardiovascular disease. And this involves training of the village doctors, but not just training, because we know training itself won't be effective, but also providing them with key performance indicators and performance-based incentives, such as payments, so that they can do a better management job of their patients in the villages. And the other study, sodium reduction, is a community-wide, population-based approach aimed at reducing very high salt intake in northern China. Our study involves 5 provinces, 10 counties, and 120 townships, including 1 village from each township. So it's a pretty large study involving 120 villages. This table shows our baseline data from last fall. I'd like to point you to the last number that's highlighted there, but I can tell you it says 33.92%, basically 34% of high risk for cardiovascular among our study population of older adults. And high risk is defined by having the heart disease, stroke, or diabetes, or having systolic blood pressure higher than or equal to 160 millimeter mercury. So it's really the high risk, not just any hypertension. If you use hypertension 140 at the cut point, it will be over 60%. Here are some snapshots showing how the study are conducted. It's currently ongoing, and with the first intervention began last November, and the sodium intervention began this May. And the study that I introduced you to about, the CRHI, is a flagship study of a center. And the center is called the Chinese National Center for Chronic Disease Prevention. This is one of the centers of excellence funded by NHLBI and in partnership with Duke and others. That's one of the 11 in low and middle income countries, and the other one Gerald introduced you about in Kenya, and this one in China. And we engage in research projects and capacity development and a variety of other things that Duke has been a very close partner and the leader indeed, including the recent trip of Duke basketball team to Beijing, that we're also part of that. So this graph shows our network. Our own center is a network of 12 institutions. Again, Duke DGHI being the lead institution for research and capacity building and other things. I did not list Professor Bennett and your colleagues, such as Professor Paul Lijing and others in this slide, but this slide listed other people who may be here or may not be here today, but I also have those 6 dots showing that there are many others not listed and hopefully more to come in the future. So that's my talk.
Thanks very much, Lijing. David?
So thank you for allowing me to be part of this. I'm going to summarize about 18 years worth of work in 5 minutes. And I want to just emphasize the fact that what we've been doing down in Haiti for 18 years has been elevated tremendously by our relationship with the Institute. We've been incredibly blessed in helping move this forward. The other thing I want to emphasize is the fact that all of this work was done by Haitians. These were community-initiated ideas. It's marvelous that cancer has been moved to a global importance recently for funding, but these people in these countries actually internally know that these are and have been important issues for a long time. So cervical cancer is a disease which is among one of the two top cancers in many low-resource countries. And it's something which really these people know can be addressed in a very simple way, because there's a 10-year window to identify and treat it, and the organ is right there, and it's very accessible. Yet it's really estimated that countries that don't have screening programs are going to have a rise in this disease and possibly even double by 2030. So as we began supporting the local efforts, we identified a number of barriers to screening, which involved poor infrastructure, lack of roads. Women had to come long distances. They oftentimes had to be working in the market. And so we oftentimes didn't have expertise in hospitals and or money. So strategies to overcome barriers have to include things like reducing the number of visits, eliminating the need for high expertise, and getting sort of creative solutions to solving these problems. Cervical cytology has been the mainstay in the United States for many, many years, and many countries in the world are realizing that this is not the ideal strategy. It's a screening technique that has a low sensitivity, and cytopathology services are expensive and in short supply. Haiti actually has 10 pathologists in the whole country. When you do pap smears, this is what you expect to see in a country like the United States. Many women being infected with the virus and clearing it, a smaller number having persistent disease and reinfections and progressing onto high-grade disease, and then a very small number that actually have cancer. When we started a cytology program in Haiti, what we discovered was about 5% of the women walking in the door had cancer, and frighteningly, not nearly enough treatable disease. So this was a concern for us, and we thought either this disease is progressing more rapidly and or we're missing disease. The answer was that we were missing disease. 85% of pap smears in women a week after they've been treated with an antibiotic have obscuring inflammation. So pap smears are not an ideal strategy, which we know. And it's a blessing, again, because there are only 10 pathologists in the whole country. So as is many countries, we've said, well, what happens if we skip the first step? We just start looking at the cervix directly. And in many countries, they're looking with no magnification. In Haiti, we proposed this. They said, this looks like substandard of care for us. We're not participating in this. We'll do what you do in the United States, so we'll look with a colposcope. The question is, how important is magnification? We don't know, right, at this point. So we did a prospective trial using colposcopy, in a blinded fashion, and basically colposcopy outperformed pap smears as we would have expected, and in both high inflammation and low inflammation settings. Cytology essentially missed 85% of the treatable disease. So a blessing that we could skip a step. So we thought, well, if the community insists on using a high magnification device, can we build a better colposcope? One of the things I do for a living is I put fallopian tubes back together. I had surgical loops. So I took the surgical loops and went to the bicycle store and got a halogen headlamp and a green camera filter, and we tested the device, and basically there's more difference between two observers than there are between the two devices. And over the last several years, we've actually refined it down to a device on the bottom right that, with injection molding, that we're starting to mass produce in Singapore. We've also been working with Lijing developing HIV or Hpv screening, and because there is an inexpensive assay coming out. When you look at Haiti, 20% of the population is HPV positive, 6% here. And the types that are there are not necessarily the two top types we have here. So we have to consider this when we think about vaccines and treatment and investing in those sorts of things. We've now proposed to the Haitian Ministry of Health using HPV, until we get HPV screening, looking at the cervix with a colposcope, which they've endorsed, and then we're actively trying to get HPV to Haiti and other countries around the world. Interestingly enough, the American Society of Clinical Oncology is coming to the same conclusion. So Haitian-run research and American thinking are coming together, and the Haitians are very excited that they've been part of this thinking. Other things out there to reduce number of visits is, can women collect specimens themselves as well as providers, looking at oncogenes, looking at computer models, eliminate pathology by analyzing the cervix, developing cancer registries, teaching doctors how to do colposcopy, developing turnkey screening clinics, and bringing the virus. So that's where we are. Thank you.
Well, first, thanks to the panelists for keeping to their 5 minutes. It made my job very easy. We're going to have some discussion up here that I'll lead for the next 10 minutes and then open it up to the floor. Very interesting presentations. This is a time in global public health where much change is going on. What you all are doing is part of the big public health conversation. But when you look at chronic diseases and the experience in this country, how expensive it is to treat chronic diseases, from your experiences around the globe, is there a cost-effective, affordable model for treatment or prevention of these diseases? And anyone who'd like could start on that.
It seems to me that in many of these countries there are resources there that we don't have here. One of the critiques that we have here is jobs going overseas. And the model of treating HIV, nobody thought we could do that, and it was demonstrated that by observing people taking their medications, you actually have the manpower there to actually do that. So I think there are resources we can think creatively that exist in these countries that we don't have here, but you have to work with them and sort of let them help problem solve.
Gary?
Yeah, I would say, of course, prevention is probably one of the most cost-effective strategies that we could utilize for many of these chronic conditions. And we certainly have a bevy of evidence-based prevention strategies that have been largely developed in the West and in Europe, and our work in part is designed to determine what the efficacy of those approaches abroad. I would say that, with some exceptions, HIV being maybe one of them, the leading one, in the area of obesity, there's been very little done in developing countries to try to understand, to really identify evidence-based strategies. So that's an area where I have to give the classic scientist answer, which is I think we still need a little bit more data, not necessarily in how to produce weight losses. We know how to do that very well, but I think as the former talk illustrated, we don't really know how to disseminate these strategies at scale at very low cost just yet, and that's really where we need to invest heavily, I think.
Jerry, your work, is it more on primary prevention or secondary when you're looking at cardiovascular disease?
So, the situation in Sub-Saharan Africa is interesting, is that, primary prevention, as has already been said, is a very cost-effective way to do this. The actual number of people who have, end-stage hypertension, end-stage heart failure, in comparison to the population is actually pretty small. And so doing primary prevention is probably going to be the most cost-effective way to do it. One of the unique attributes about Sub-Saharan Africa or many developing countries is the vast investment that's already put in place to treat HIV and AIDS. And so not only have medications been delivered, but also health systems have been improved. Community health workers have been used in very novel ways to task shift away from the health center out into the community. And so it would be, in my opinion, wasteful to try to create a new vertical program to say, well, now let's create a chronic disease, international initiative, but instead to build on the experience of HIV and partner with health systems that are already doing great work in HIV to expand into non-communicable diseases.
Lijing, in your setting, where does chronic disease fall in terms of local priorities?
Well, in China, the government leaders, mostly pushed by the experts in the field, they have recognized the problem of NCDs. For example, they have listed diabetes and hypertension as the two diseases that they would address as a public health issue. So there are a recognition of that. But coming back to your question of whether there is a model that we could use to fight the problem of chronic disease, I think the answer is yes or no. Yes, because as Gary said, prevention is the key. So if you think that's a model, then it's yes. But it's also no, because we know NCDs are a group of chronic diseases, even though they share many common risk factors. But preventing obesity is different from preventing smoking. And promoting physical activity is different from having people make a healthy lifestyle dietary choice. So we really don't have a model in how that works. And I think I want to give one anecdote story, and I'll end my dialogue with that. I walked into the office of the Beijing office of one of the largest philanthropical organizations in the world, and I said, please support programs on NCDs. They've done a lot on infectious diseases, rightly so, but I said, please also support NCDs, and they said, I'm sorry, we don't want to because we don't see any quick and easy fixes to solve NCDs, and this is one mentality that they still have.
I wanted to ask a policy question. Gary, in your presentation, you showed a slide that had a Kentucky Fried Chicken and was a Coca-Cola.
I didn't take those photos.
But when you're looking at chronic disease and some of the drivers, you're looking at food and food choices. You're looking at tobacco. And a lot of that is multinational companies marketing products. With that comes jobs as well. What are you seeing in your various settings in terms of interest in policy approaches to primary prevention? Is it realistic to think that you can do that, or are they going to become like America, 60% overweight and obese?
I have to believe that anything is possible, but that is likely to be a very tall order. I think I would say too that I didn't think that there was much hope for us doing much on the policy scene with respect to containing the food industry or eradicating food deserts in the U.S. either. And I've been very surprised that First Lady Obama's efforts seem to be paying off, and that we've had a number of food companies and large retailers make announcements that effectively will result in positive change here in the U.S. So that's been quite a surprise, and I think that the example that example is an important one, and suggests, as Lijing was mentioning, that getting high-level buy-in and collaborative efforts between governments and in my area, the food industry, is going to be absolutely essential to curbing those problems. I don't see this same kind of capacity for policy solutions independent of strategies that also embrace the food industry as well. Just a very quick anecdote. One of the things that I was working with participants of ours in one of our trials in Beijing and was talking about the importance of staying away from fast food. And I was reminded by one of our participants that that they really had never gone out as a child. And this participant, when he had reached a sufficient age and had sufficient disposable income, took great pleasure in going to the local KFC and bringing his kids. That it was a marker, it was a personal measure of the degree to which both China had developed and that he had succeeded. And so it was then I was reminded of similar situations here in the U.S. And sometimes these things mean more than just just the KFC at that block. They're very complicated strategies that require multi-level solutions.
I want to open it up to the floor. There are microphones. When you come to the microphone, if you could ask questions and not give talks, and identify yourself and your affiliation, that'd be great. Thanks.
Colleen Cunningham, Pediatrics. Just many of these chronic diseases start during childhood, or at least the habits that lead to them start during childhood. In some of your interventions, I'm just curious, have you looked at whether or not there's an impact on your intervention in the children in the household? So when you do a walking intervention for the obese adult, do you look at the child outcomes in the same household?
We haven't done that yet in China, as our work is just beginning, but certainly from the U.S. experience, there's good evidence that intervening on parents, Sarah Benjamin Nealon is in the room, is one of the world's experts in this area, but intervening on parents seems to be an important way of addressing childhood problems. I would imagine the same would be true.
I can give you one example of the sodium reduction work we're doing in rural China, in the China Rural Health Initiative. We do involve the whole community, and we have special tailored health educational campaigns toward children. And it's took the message of reducing salt intake to heart, and they do have this effect actually on the whole family even. We call this the strategy, the little hands holding the large hands. So that's just a small example that we're having on salt reduction.
Over here.
Viviana Martinez Bianchi, Department of Community and Family Medicine. And this is for the panel as well as some of our leadership in global health as well. Much has been said recently about the UN, the NCD summit at the UN, about the need for more teeth to the declaration, the political declaration. So my question to members of the panel who've been all over the world and our leaders in this field is, what can we as members of civil society and academic centers do to actually help or work behind the scenes for the UN to put teeth in the next year? Because the final declaration is going to be by 2012, December of 2012. So what can we do as members of civil society, as academic centers, as researchers, physicians, PhDs, etc., to help to get this so that there is appropriate funding, so that the funding is not just vertical but horizontal and takes in consideration the needs of all these different societies in the world.
Thanks. Anyone on the panel like to address that?
Sure. Well, it was says the UN meeting was was a member nation or member state meeting, and there wasn't much that involving civil society in the actual discussions. However, based on our experience in Kenya, what we've actually done is we've actually taken our direction from the Ministry of Health and actually partnered with the Ministry of Health. Our program started as an HIV treatment program. And because of the need that we saw, day to day to actually start to address the non-communicable diseases, the program actually went to the government and said, hey, would you mind coming alongside and helping this? And it was that partnership with civil society, with the academic institutions and government to actually help the Ministry of Health in the country understand this was a large problem. And I was very impressed to watch some of the roundtable discussions where one of the ministers of health from Kenya was actually a very strong proponent for including NCDs and putting some more teeth into the political document. So I don't know the 10,000 foot level response there, but I think just being on the ground and partnering with not only other institutions, but also look for those opportunities to engage the government when it's possible, helps to sort of filter the message out.
Peter, can I put you on the spot on that, and maybe with a microphone?
No, I think that there are several issues here. The one, I think your point were okay there, is very important. So there is in the declaration, it is stipulated that within a year, some specific targets have to be approved. And that is, I think, the key is now to make sure that this is not only left to WHO to do it, because there are many fights going on. Let me put it this way: often experts are the worst enemies of the cause and of the case, because they can't agree on whether it is cancer survival using this method or it's this and that. So it's very important that, and it's one of the things that I did in AIDS, and as Mike knows very well, Merson, you have to bring together a unified strategy that is simple, and you have to agree, like, these are the 5 things we're going to do. And the rest, sorry, they're very important, but if you want to achieve something, and that's where I think from the academic side we can also work together, I would say, with the NCD Alliance, which has done a fantastic job. Let's not forget that this field was dominated, with all due respect, but it's oncologists and then endocrinologists and cardiologists not talking to each other. And because of this summit, their organizations, and including also patient groups, came together. And I would say I would put a lot of time working with the NCD Alliance, but then also at the national front. Because in the UN, it's the so-called member states that really, that will make it and that have to agree on it. Academia itself, we have not much to do. We can publish a paper and then say more research is needed and so on. That's not going to make it. Well, you know all this very well. So I think it's very important, and in this, it means for the US, make sure that in Washington there's lobbying, and also that the members of Congress here are aware of it and so on. It's going to be, the key issue is that the next one is funding. But I think it's going to be very difficult to mobilize funding if you don't say for what exactly. And what is expected that we can, what's the return on the investment? It's not enough to say NCDs cost 15 trillion whatever and dollars and so on. It's if we invest 1 billion, what's going to be the return and so on.
What are the targets?
And how we measure it.
Thank you.
Thank you. I'm Laura Hemeke from IntraHealth International. I think I'm a little tall for the mic. Actually, my question is related to the previous one. Do you think it's helpful to call diseases non-communicable diseases, given the fact that there may be no such thing? And by thinking of it as those non-communicable diseases, I think there's a false sense of protection for people who feel like they're not exposed to those NCDs. And whether it's healthier for the community and for funding levels and for attention to make a distinction perhaps between chronic and acute or some other distinction that wouldn't put them into that other category, especially as we're learning more and more about how all diseases are communicable at some level. Thanks.
So
David.
there was a recent statistic which estimated that 25% of cancers in low-resource countries was linked to infectious disease. Whether that's that high or not, but the fact is that there are many cancers that are. So you're absolutely right. It's a blurred distinction.
I think you asked a great question about the name, and indeed, in the academia, we don't agree on the names and how to call it, and calling it something that's not is not helpful, but I think the recent consensus is that it's settled on NCDs, and we're hoping that people will know it as NCDs as people know it as AIDS. Instead of, if you walk to a person on the street, they may know NCDs, not necessarily what it stands for, but just generally know it's, a group of chronic disease. That's the consensus.
Because anything that starts with non is a non-starter.
I can tell you at ABC News you will never hear non-communicable disease. I mean, it's unintelligible. But maybe this is like your global health version 1.0. This is NCD version 1.0. And as the field matures and groups come together, there'll be a term that resonates with people. Yeah. Yes.
Hey guys, my name is Sarah Timberlake. I'm with the School of Nursing here, and I've been thinking a lot about how chronic diseases are largely a behavioral issue, it seems like. And I'm wondering what you think about the idea of incorporating training for medical and nursing students for motivational interviewing and other kinds of health coaching strategies as part of the curriculum as one intervention for addressing this tidal wave of especially cardiovascular disease coming up.
Sure, I'd be happy to address that. So as I alluded to earlier, task shifting, moving away from the model where there's a physician who sits in a clinic and waits for patients to come to them with a complaint as it relates to NCDs or however we call them, will slowly be a way of the past as it relates to low and middle income countries. It's just too expensive to do. There's not enough physicians to do it. Roads, fuel for vehicles, et cetera, we could go on. And so, so this concept of moving the onus of finding these diseases and doing things to treat them, it needs to move out into the community. And that's one of the things that we've done in Kenya is actually employ nurses or other, maybe the equivalent of a physician assistant level of training here in the U.S. To actually engage the communities where they live, their own communities. One of the programs that we have out there involves diabetes, and some of the actual diabetic patients have become employees of the program, and they then help to teach other patients how to manage their own condition. And all of these motivational interviewing, mobile technology, messaging that's relevant for our community has to be the way that this moves forward if cost is a concern, and I think it is.
Just very quickly, I think in the obesity area, if you want to lose weight in the United States, one of the last places you want to go is your doctor's office. I mean, there's actually very little information that you can get there, and we know that counseling for weight loss tends to be lowest for those patients that are most at risk, and that effect is magnified in the developing world. And so I think the training providers, particularly frontline providers in behavior change, is a really important thing. I guess from an academic perspective, though, I'd say that one of the things I've been struck by is the decided lack of behavioral science theory in non-Western nations. And I'm not sure whether motivational interviewing is the right strategy, but I think we need to know more about the strategy that will be most effective for behavior change at the provider level.
Yes.
Herbert Ban, Medtronic. Thanks for highlighting the importance of public-private partnerships and leveraging existing platforms like HIV/AIDS clinics to treat NCDs. I think both are critical. One of the other things that came out of the UN meeting was the need for new models of training and educating healthcare workers and healthcare professionals. And how is it that we can train large numbers of people very effectively to work in multidisciplinary teams? What are the new transformational models for doing that? I'd be interested in your perspective.
Anyone address the issue of training? David?
I'm not sure that I can directly address that from the work that we're doing. I mean, we do believe that that the infrastructure is not there to deliver the care that we want to provide at the physician level. So focusing on community health workers, nurses, the infrastructure that does exist is very important. But I don't think I can, as an expert, directly address your question.
Anyone? Maybe we'll pass and we can talk about this with health systems in the third panel. I want to encourage students who are here to not be shy, to come up and hit the microphones. Your questions are as important as anyone else's, so please don't be shy. Peter.
Thank you. One of the most controversial issues in New York was regulation and regulatory things and the law and all that for policy. What do you see as and in the UK there's a big debate about it. It's totally political. How do you see things? Because it's New York City, I think, provides probably one of the best examples, become one of the healthiest cities, and that's because of, I think, Mayor Bloomberg, and who imposed a number of things that in the beginning people said absolutely forget it, impossible, etc. And they've shown that it's possible. But like in China or in Kenya, etc., the countries, how do you see things from there?
Well, I'll respond first. A sentence with never in it. I think I will never go into politics myself. But to respond to your question, I really love what you showed. One of the slides you showed, it goes from individual plus population plus environment. I truly agree with that. I think environmental changes involves not just economical, social, cultural, physical environment, but also political environment. And regulation, to me, is really key in dealing with NCDs. There's no way around it. I think we have this tendency of seeking comfort and pleasure as a human being, and myself included. It's not that people's lifestyle hundreds of years ago were inherently healthier than us. They live in an environment, they lived in an environment that made them so. Having more physical activity, having a low-fat, low-sugar diet. But now our environment is different. We can't just rely on individuals. I truly think regulations are key.
Do you think you see a day where there'd be a ban on indoor smoking, workplace smoking, restaurant smoking in China?
Well, there is a ban, but what lacks is the reinforcement of how to make the ban work.
Yeah, I mean, China's had some interesting policies, physical activity in schools and the like. I think the issue is really is making the case for the need for policy solutions. In the area of obesity, one of the things that I think is most intriguing about China is that obesity has the potential of having a huge economically destabilizing effect on the country. We know that obesity is directly tied with productivity, particularly for people in manufacturing jobs. You can imagine with the experience of type 2 diabetes at very low levels of overweight. There is great potential in the next 20 or 30 years for an overweight sedentary population with type 2 diabetes and cardiovascular disease that exerts a destabilizing effect on the Chinese economy and by extension ours. And so I think we really need to be making the case to policymakers that it's not just about health, but it's also about economics, and it strikes me that that's something they tend to get more excited about.
Thank you. We have time for one more question before this panel wraps.
My name is Christine McKenna. I'm Duke class of 2008. So I have a question, sort of follow up from previous conversation we were having. Is there a way, over the last 10, 15 years, there's obviously been a big buildup of civil society and infrastructure for AIDS, TB, malaria, and that whole network that exists. Is there a way to tap into that and sort of build on that infrastructure that already exists to build the political will and also the infrastructure the same way you're doing in Kenya with the cardiovascular interventions, and to be able to leverage that and to be able to build a political will moving forward.
We'll touch this one lightly because we are going to get into some of that in the third panel.
Sure.
What do you see?
I'll mention here, and I'll put a shameless plug in for a group that you may be interested in joining. So there's a Young Professionals Chronic Disease Network, which is a network of just that young professionals of many different disciplines, where we all just sort of get together, share opportunities, share ideas. They were present at the UN high-level meetings. There's definitely a need for that type of group as we approach NCDs. If you look back at the HIV/AIDS epidemic, there was a group of people who said, this is an important issue for us. We need attention, we need funding, we need research, et cetera. And you need that same approach for NCDs. It's easier to garner that much attention when you have a lot of people with a similar interest coming together.
Well, David, you quick comment?
Well, just a quick comment. I mean, actually, there is a huge effort now with this pink ribbon, red ribbon campaign to actually link an AIDS-related malignancy to the PEPFAR money. And I think that having been such a successful use of money reducing HIV, using that infrastructure to use those clinics, I think is something that actually is going to happen.
We're going to get into those issues much more with our third panel. I want to thank our panelists for a really engaging first panel. Well done.